I'm really excited today to have you meet with Ben Johnson, who is with the California Hospital Association and a colleague of mine. He has been our point person for the Office of Healthcare Affordability, which is a new statewide office that was established, I believe, about 2 years ago. Um, that is really focused on a very important aspect of healthcare, which is something that I know top of mind for all of us as consumers, but also for those of us in the healthcare field, is how to make healthcare more affordable and accessible. This is, it's the holy grail of healthcare. The office has a very broad mandate and is really, I don't know. I'll let you kind of explain what they're doing, Ben. But they just started their work, and I think it's important to get a feel for what they're looking at, their roles, responsibilities, and how what the decisions they make might impact access to care close to home for us. So, Ben, I'm going to turn the table to you, and if you're able to share your screen and get started.
Yeah, thank you so much, Rebecca, and thanks for the invitation and intro. Great to be here. CHA is representing roughly 400 of the state's hospitals and has been closely engaged on issues related to affordability, including the Office of Healthcare Affordability, since it was initially a concept that was going before the legislature. In fact, it was before COVID that similar offices or a similar structure was proposed, but COVID was a major interruption to everything we're doing in life, including the passage of the legislation that created it. So definitely want to go into a little bit about the history, its impetus, and what it's been up to the last few years. Maybe some of CHA's concerns about some of the policy directions that it's been heading. And I'm happy to share this deck with folks after the call as well, if it would be helpful. A lot of detail that we won't go all the way through, but want it to be available. Is that showing up for folks okay? Okay, great.
Great.
All right. So, Office of Healthcare Affordability. I don't think it's probably not a surprise that there were major perceptions among both the public and policymakers that healthcare is challenging to afford. That a fear of getting unexpected medical bills, or if high cost drugs were needed, what would be the copays there? And so policymakers were really honing in on these issues around at the start of 2020, and then they revisited the same challenges in 2022 after the pandemic had started to subside. We know, I think you all know likely that per capita healthcare spending is higher than almost any other peer country here in the United States, if not every other sort of economically developed peer country. Got lots of folks that are uninsured, underinsured, though there has been significant progress on that. Challenges with high deductible health plans, with surprise medical bills, these sorts of things entering the public consciousness. And so state policymakers wanted to be responsive, and these policymakers included key members of the legislature, like Assemblymember Jim Wood, former chair of the Assembly Health Committee. Gavin Newsom, the governor, was very interested in making a mark in this realm, maybe through single payer or through this alternative structure that was ultimately approved back in 2022. And there were various stakeholders that were very engaged and enthusiastic about a concept that ultimately has been experimented with in other states and is starting to spread across the nation, with California being the last major entry into the space of what we could call cost commissions, but agencies that are tasked with measuring and, in some cases, aiming to restrict the growth in healthcare spending over time. So ultimately, various policymakers and stakeholders came together, borrowed the concept that was really initially started in Massachusetts about over a decade ago now, but has spread across the coast. So it was 2022 that the office was actually enacted via state budget legislation. And this office is tasked with maybe three major responsibilities. First, reducing the growth in healthcare spending. Second, kind of thinking that one of the underlying causes for high healthcare costs is maybe excessive consolidation. The office now has a key role as well in monitoring and reviewing certain types of market transactions. And then to try to ensure not a race to the bottom, that we're not just taking that the state's not just taking a sledgehammer approach. It does have various activities related to the promotion of quality, value, workforce stability, and so forth. Those CHAs had questions about how well those objectives have been integrated into OCA's overall set of activities. So it's not, it wasn't established as a wholly separate entity. Instead, this office has been, sits within the Department of Healthcare Access Information. Formerly it would be known as OSHPED. So hospitals have been intimately familiar with this state office as they were tasked primarily with overseeing the state's hospital seismic compliance rules. They also have major workforce programs. And so they put this new office within HCI under the direction of HCI's director. But they also established a board which has key decision-making powers over certain aspects and, in fact, very key decisions that the office makes. And then finally, there is an advisory committee that's separate from the board. The board is really comprised, I'd say, of one would call them outside experts, not folks who are directly involved in the provision, administration of healthcare. So, for example, there are no hospital leaders, physician organization leaders, and so on the board. And that was deliberate in terms of the legislation. But the office did want to get input of folks who are more directly involved in the administration and delivery of care. And so that's where the advisory committee sits and provides advice to both the director and the board. But ultimately, it's the board that does make many of the key decisions. And I just have the list of board members here. In case folks are familiar with any of those. And so it's ultimately an 8-member board with 7 voting members and currently 1 seat that's unfilled. Now, OCA is not strictly a hospital regulatory agency. It has a broader purview that includes payers, providers, as well as what is termed fully integrated delivery systems. So the payers does include health plans and insurers. It in fact does include Medi-Cal and Medicare, though it hasn't really been tested to the extent to which this agency should it maybe differ in a conclusion about how much should be spent in the Medicare program, how those differences would be resolved with the federal government. So a bit of an untested concept. For how closely involved it will be in Medi-Cal and Medicare spending decisions. So I'd just say that the focus undoubtedly is on the commercial market. So that would include certainly the coverage that you receive through your employers, as well as individual market and small business, such as through Covered California. It does regulate a range of provider types, so that does include hospitals, but also physicians, clinics, nursing facilities, and others. And then for fully integrated delivery systems, that's just a unique definition that applies to Kaiser as a whole. Now I'm going to go a little bit backwards here in terms of what are its major roles. As we said, its major roles are reduce the growth in healthcare spending, oversee market transactions, and promote value and quality in the healthcare system. OCA's, I'd say, really focused on that reducing healthcare cost role. And so we'll spend a lot more time on that. And that's certainly where some of CHA's questions have been. But do want to give a short overview of what's going on with their market oversight functions. Essentially, you may be familiar with the Attorney General process where if a nonprofit hospital wants to merge with another hospital, for example, it undergoes a review from the Attorney General. OCA's role is somewhat similar but somewhat distinct. There's a notification process of an intent to transact for similar types of transactions, though it's not limited necessarily to, say, if it's a hospital affiliating with another hospital. This office, as opposed to the Attorney General, looks at things like vertical integration. So if a hospital were purchasing a medical group and so forth. So it is a somewhat broader purview, but it does have a somewhat more limited authority in terms of what types of actions can it take, even in the case of when it does see maybe excess consolidation as the result of a merger. And that is because the role of this office is to report information to the public. It could refer to an entity that has enforcement powers, but in and of itself in this realm, no enforcement powers. Ultimately, the technical term is they do conduct cost and market impact reviews. So they receive a notice, they decide whether or not that transaction is going to be materially impactful, such as really promoting market share for a single provider in a given market, if it's likely to raise prices, reduce access, and if so, though, they will conduct a lengthy study that could take the better part of a year, and in which that transaction couldn't move forward until that report was completed. So what we're seeing ultimately is, I think, increased transparency around different types of transactions. OCA does have a website where it tracks all of its notices, for example, and so you sort of get some more insights into what's going on in the market. And so it is actively fulfilling and carrying out this process today. And please just stop me and interrupt me if you have any questions. We'll move through topics pretty swiftly. You can always return to them, but please do jump in. In terms of promoting value, OCA is really doing so within 4 domains. And I won't go into details on these, but first, they're operating under a sense that, you don't want to just pay for additional services, that could promote overutilization. And so they're aiming to encourage a shift to alternative payment methodologies where there's maybe a quality component of the payment. It could be something like a capitated arrangement where you're responsible for maybe a member's full health outcomes rather than simply responsible for whatever services they use. And so OCA is encouraging greater adoption of alternative payment methodologies. Second, on workforce stability, there's certainly recognition that aiming to constrain cost growth could put jobs under threat. And so there are standards. There aren't enforcement teeth here, but there are standards and effectively reporting by which OCA is going to track what are the trends in workforce stability. They have, in fact, promulgated a set of quality and equity standards, really borrowing from what exists from other regulators and payers. And so they'll be tracking those over the years as as new data come in and so on. And then finally, there's certainly a belief, and I think some validity to it, that healthcare in the United States or in California overly focused on acute care or specialty care, don't have enough early intervention, prevention, primary care, behavioral health, and so forth. And so rather than trying to reduce the growth in behavioral health and primary care spending, they're actually trying to increase investments in those areas. And so effectively, they want to see the share of spending in those 2 domains increase relatively to other components or sectors within the healthcare space. And so that really summarizes those activities that aren't directly related to healthcare spending. But again, I think really the marquee responsibility of this board is to constrain the growth in healthcare spending. And they do so here primarily through tracking spending. They're going to gather information from hospitals and from payers, and release reports on what have been the trends in that spending. And then they're also setting statewide spending targets. These are target percentages for the annual growth in per capita healthcare spending. So they are the limits effectively of how much healthcare spending could grow in a given year. The targets, which you can see on the right, the board has promulgated its initial 5-year set of targets. They were set on really the principle that the office doesn't want to see healthcare spending grow faster than household incomes grow. So a good principle, though in practice, we're certainly seeing some challenges to it. But they did allow for as well a glide path that allows that target to ramp down over time to allow some adaptive period. In addition to that, OCA has focused some greater attention on the hospital field as well. So OCA does have authority under legislation to establish various sectors and to differentiate the spending target for different sectors. And so OCA did move forward in establishing a hospital sector and went even farther than that and undertook an exercise to identify what they call as high cost outliers. Ultimately, they ended up identifying 7 hospitals across the state and have put even lower spending targets on those hospitals. Certainly can get into a lot more detail on some of the decisions that were made around which are those high cost hospitals. We don't necessarily see a ton of similarities between several of these, other than maybe being in high cost areas and so on. So certainly was a controversial decision among the hospital community, but it did move forward nonetheless. Critically, I want to go into what happens if you grow over the target. So this spending target regime, as in other states and as in OCA, it's not a limitation on what your negotiated rates are, say with a payer. So, for example, if Alameda Health System is negotiating a rate with a payer, it's not a rule that says you may not ask for a rate or sign a rate increase of greater than 3.5% or 3%, whatever the target is that year. What it is instead is they're going to look at your spending growth on generally a per capita basis, or for hospitals on a per service basis. And if it grew over that 3.5%, then an entity could be found liable for violating the target and be subject to various types of enforcement actions. Now, it doesn't guarantee that they would be penalized. There is this pre-enforcement process, as we describe it, where if the office determines that an entity grew excessively high, but for justifiable reasons, they wouldn't move forward with the enforcement process. But for entities that they find that had unjustifiably high cost growth, it would trigger this progressive enforcement process, starting with technical assistance from the office. Here are ideas for how to get cost growth down. They can bring a hospital or health plan leader before the board and have them testify as to why their costs grew as high as they did. They can impose performance improvement plans or even assess administrative penalties, which we think ultimately they haven't established what those penalties are yet, but they likely will be potentially in the tens of millions of dollars for a violation. So lots to be determined here, but just wanted to give folks a sense of what that enforcement process would look like. And now, as I said, we're not creating this on our own. California has really borrowed this model from other states, but in fact, we only have one enforcement action that's been carried out so far. This slide just highlights a little bit about what it looked like, and it ended with a performance improvement plan that was successfully completed for Mass General Brigham, where they implemented various cost-reducing strategies such as price reductions, moving care to lower cost sites, and so forth. And happy, of course, to share that slide. Just a couple more slides to go, and then happy to take any and all questions. Just want to highlight that as of June of this year, OCA released its first report on the annual growth of healthcare spending. Certainly recommend checking it out. We have a couple highlights that we put together just on this slide. Now, this is before any of the spending targets took effect. This is kind of what they call a baseline report, just to really level set what are the trends in healthcare spending. And it revealed a couple of interesting things, we certainly think. First, coming out of the COVID period, you can see on the graphic on the left that spending growth was significant, was very high, much higher than the future spending targets of 3.5%, 8.2% in total spending growth, and 8.4% per capita. So significant cost growth, showing that there's significant progress that would need to be made to ultimately reach the spending target. On the right, as you can see, there are breakdowns of what are the major contributors to the healthcare spending growth. We saw for hospitals, outpatient, grew at a pretty significant clip on the hospital side, not quite at the statewide trends, but 6.5%, pretty significant. But inpatient was quite a bit diminished at 2.3%. And then we do see significant growth in the area of health insurer administration and profits at almost 22%. Significant pharmacy cost growth as well, though that doesn't include the impacts of rebates. So, starting to see what the transparency provisions of OCA are allowing in terms of looking at what those trends are in healthcare spending and kind of what are the subcomponents of it. Now here, just gonna move on to some of CHA's major concerns with how the office has operated, and I think some primary concerns are whether or not the office has really adequately accounted for some of the macro trends that affect healthcare cost growth within its spending targets, within its goals. And what are the costs of ignoring some of these underlying features and drivers of healthcare cost growth? Top of mind, certainly right now, is all the impacts of HR1, the one big beautiful bill that is stripping billions and billions of dollars from California's healthcare system, particularly for safety net hospitals, clinics, for Medicaid beneficiaries who really don't ultimately even didn't even come in with adequate access to begin with. So major concerns about what we see as a major new regulatory effort in the Office of Healthcare Affordability that does aim to really limit the resources going to hospitals and other healthcare providers from the commercial markets, from employer-sponsored markets, and so forth, and what that's going to mean when it's compounded with the cuts that are occurring on the safety net side, on the Medicaid side, on the ACA subsidy side. From OCA alone, we see $40 billion in reduced patient resources for care, given what pre-existing trends were in hospitals' cost growth due to high labor costs, due to the cost of procuring many cancer drugs, new other types of treatments, upgrading facilities due to seismic compliance rules, and so forth. So we see a gap that is just going to grow over time between the cost hospitals are incurring and the resources that they would have available for care under OCA's cap. We're worried that would, despite workforce stability rules, result in significant job losses, and without action being taken, preventive action, many more hospitals operating the red. Currently, already, about 50% of hospitals have negative operating margins, and we project those to grow to nearly 80% by the end of the spending target period. And so just a few takeaways here is what we've been pushing for, and certainly would encourage all those who are engaging with the Office of Healthcare Affordability or with state lawmakers, local policymakers with an interest in what this office is doing, is just, I think, a much greater focus on the resources that are necessary and some of the trade-offs that come related to access, quality, and workforce stability of the cuts that are due to the cuts that are coming both from OCA as well as from the federal government. Greater recognition of cost drivers. For example, we have a new state healthcare worker minimum wage law that went into effect a couple of years ago. But we need that recognized in the spending targets and so forth. That does impose new costs in the system. Reevaluation of these targets, given the massive cuts coming from the federal government, potentially cuts coming from the state government as well. We've seen pullbacks in coverage already due to state fiscal pressures, and more such healthcare cuts could come. Looking for rules that account for patients' needs to a greater degree, and I think allow for greater predictability in planning for healthcare entities. Don't they? For example, if a healthcare entity takes in more revenue but reinvests it in their community to expand primary care clinics and so forth, not really certainty today over whether or not that they could still get dinged under OCA's rules, and ultimately kind of pay the price for in compliance terms for those investments. And then finally, and perhaps most importantly, just continued evaluation of whether patients are receiving the full benefits of OCA's spending caps. The focus has really been on hospitals. The focus is really on the revenue, the resources that providers receive from health plans or other payers, and not a lot of focus is on what are workers paying, what are their employers paying for premiums and so forth. What are the deductibles? And the limits, in fact, don't directly apply to an individual's premiums. And so we're trying to provide significant oversight, certainly, of whether or not OCA's activities are translating into the types of affordability improvements that we do know Californians need. So that concludes my presentation, but happy to take lots of questions. It's a big, complicated subject, and there's lots underneath the surface here. And again, just thank you all for your attention, and Rebecca for the invitation.
Thank you, Ben. Appreciate that. This is a lot to absorb, and the hospital and community has been focused on the Office of Healthcare Affordability for many months, and I will say, still trying to uncover all of the impacts and effects that it has, especially for our not just for our facilities, but our communities. Um, I if anyone has a question right off the bat, feel free to raise your hand or shout it out. Sharon, were you off your phone
I
for a
did.
reason?
No,
Okay.
I did. Hi, Ben. This is Sharon Jenkins with Drum Your Health.
Hey, Sharon.
Hi, thank you. That was good. Or else I'm just getting used to hearing all of this, and every time it's easier to understand. Not good, but easier to understand. What I just am pulling here, your last point. What is needed. Really making sure that all this entire exercise actually makes its way down to the patient premium. I mean, I think that is I don't know whether to laugh or cry, but it's just almost like the Office of Healthcare Affordability and the cost of healthcare and all these different things, and we don't even know if what we have put together or what they have put together actually makes it to the patients. I'm kind of stunned at that. So it's just a comment. It's not a question for you, Ben. Thank you.
Thanks. Yeah. I mean, it's a hugely important question, and we're kind of wrestling with, I think, a disconnect, if I may opine in a little bit in reaction to your question there, Karen. We're seeing exorbitant premium growth going into 2026. When I look at rate filings and so forth, they're on the magnitude of, say, 10%. Now, I said that that OCA spending targets, they're not caps, they're not rate caps, the negotiated rate caps, but they are meant to influence those negotiations. And so we're really sort of sitting here at a loss of what's happening here if negotiated rate increases are, kept as intended to these spending caps, but premiums anyway grow at the 10% level. Now, of course, some of that could be utilization, but likely not all of it. And so just a really important area for oversight.
And Ben, you kind of quickly glossed over, but the data that OCA is looking at, where are they getting their all the data for their reports and all of that?
Yeah, I skipped over that almost entirely, Rebecca. So, two major data sets. One is entirely new, and that is this is reporting required of the health plans and insurers. So there are new reporting templates, and they go to the health plans and they say, how much did you spend on healthcare? They don't ask them how much did you collect in revenues, just how much did you spend on healthcare. And then they look at that on a per member basis. And then for physician organizations in particular, they then attribute it down to a physician organization based on that member having a relationship, typically a primary care relationship with that physician organization. So that's one set, and then they can look at it on a per capita basis per patient or per member there. But for hospitals, it's quite a bit different. Instead, they're using long-standing hospital financial reports that hospitals have been providing the parent organization, the parent department, HGUI, for many decades. And they're looking at what is the growth in hospitals' revenues on an annual basis per service. And so that is the main piece in what they'll be ultimately holding a hospital accountable for against the spending target. So when they say it's a cost targeted spending target for a provider like a hospital or a physician organization, it's not how much they spend on care. It's the resources, the revenues that they receive for.
So what you're really saying is it's a sort of a cap on how what you can receive in revenue.
For the providers. But for the
Providers.
plans, it's a cap on how much they can spend. Yeah.
Okay.
Bit of a
So
bit of
so the disconnect is happening in my brain because I'm thinking, how is a provider, a primary care clinic going, if they can only receive so much in revenue, how are they going to maintain or even expand their services? Isn't that a mandate also of the Office of Healthcare Affordability to do more primary care, more behavioral health? But if they are constricted by the revenues, it doesn't seem to add up.
Yeah, it's not real. They have never been, I'd say, truly clear on how the their investment sort of promotion actually interacts with the spending target. In practice, my interpretation of it, at least, is that it's gonna be essentially an exemption. They're not gonna hold if it's a primary care, for example, primary care doctor, you're going to not be limited to the 3.5%. They'll know that to reach their benchmark, they need huge growth in that space. And so they will be willing to accept higher than the spending chart revenue growth increases. But it's not clear, and that of course is limited to the primary care space, and even probably won't be even all of the behavioral health space. It probably will be limited to ambulatory behavioral health when they finally do get around to setting those explicit rules.
Did you have a question, John?
Yeah, hi,
Yes, please go ahead.
Yuan, professor at St. Mary's College of California. I'm very pleased to hear that OCA is focused on the affordability from the employees and the employers' perspective. So, for example, I work for a small liberal arts college. So our healthcare cost is, like 10 times of faculty who work for, California state system universities. simply because we are so small in number. We have literally no bargaining power when we deal with insurance companies and the brokers of insurance companies. And so I feel like I've heard that there's a bill that passed several years ago that allows small colleges to kind of form some kind of association to then buy from an insurance as kind
Hmm.
of a, I don't know if that happened or not, and if that's an option, that can definitely reduce the, the faculty and staff employees for small organizations. But I don't know if that's something that happened or not, or if there's a platform, because there's nobody who is motivated to do that, even if that is a possibility.
Uh, yeah, it's a huge point. I'd want to follow up on exactly what law change and whether or not it's prospective or retroactive. I know there were certainly various legacy types of arrangements like that that the legislature's been interested in protecting. But what opportunities for growth there are. Ultimately, it's just a really good point. I mean, one thing, hospitals, there's, certainly they can be big organizations that can be influential in negotiations with payers, for example. But payers tend to be much bigger and much bigger than the employees at a small liberal arts college like yourself. And so we've been certainly encouraging OCA to look at those aspects of market power and dynamics to ensure that on premium negotiations that workers and employers aren't getting taken advantage of there as well. So good, excellent point, but we just need to follow up on specifics of that legislation. So, thank you.
You want to see if there's any other questions. Um, Ben, I don't know. You mentioned a little bit about the high cost hospitals and, they set the 3.5% spending growth target for hospitals specifically. Um, and I think you might have said that the HCI is going to go back and review those lists of high cost hospital targets. So, what does that look like? Uh, what are you seeing there?
Mm. Well, we don't know yet. The reevaluation hasn't occurred yet, but we do think it's going to occur likely over the next 6 months. And so what it's going to involve is certainly just getting an additional year's data and seeing where things fall. So when they determined which hospitals they would designate as high cost, they used a data set that looked at relative costs of these hospitals compared to others from the period of 2018 through 2022. They'll have 2023 data as of this fall. And so maybe late this year, early next year, they're going to be doing data runs that allow them to see, hey, did a hospital fall off of their criteria? Did were new hospitals added on? And then they'll actually make decisions. So they're not required to update their designated list based on that data, but they're going to be presented that information. And by they, I mean the board. They'll be presented this information and then they'll have the opportunity to maybe make modifications. We'll see. It'll be an interesting question. One of the major challenges CHA had, I mean, the details of reporting can be so important, is that hospitals always have been filing these reports for many years, but many of the fields didn't sort of drive state policies or reimbursement in in major ways. And so I think there's significant cleanup to some of the data that hospitals have been doing. And so we're starting to see maybe some refilings and all like just additional attention given to these reports and what they ultimately spit out in terms of performance on various metrics, such as on the office of affordability.
Um, and this is Sharon again. In a follow-up to Rebecca's, do you have that one slide? Can you put up that one slide? Because wasn't there some back and forth about which hospitals were on and off for a little bit? Do you have that? So your slide shows like, right,
I only have the 7 on that list. on this in this deck here. I can pull it up though.
But that's as of right now, right? That's
Yeah.
the 7 that they are all looking at right now.
Yep, exactly. So these are the 7 distributed largely in the Bay Area. So including the East Bay in Washington Hospital in that case. There were additional hospitals. There were 4 additional hospitals that were being considered as of the date that they decided on this list, but they got removed due to being either very small or for having maybe significantly improving trends um, potentially. And so a few hospitals did get removed. They had gone through various sort of metrics when deciding how to do this exercise. And so they looked at various things. They looked at all payer revenues per unit of service. They looked at operating margins. They looked at a sort of analog to a reference-based price comparing to Medicare. And all these different metrics tended to point to different hospitals. And so ultimately, when they settled on a couple of metrics, it whittled the list down to 11, and then they ended up removing a few more. We'll see. They could change their definitions of how a hospital is defined as high cost, or they could keep it consistent over time. They have a lot of flexibility here.
Thank you.
Mhm.
And this could be a bit disruptive for hospitals because you could be off the list, 1 year, they reassess the data, then you're on the list, and then you've all of a sudden, on a dime, you've got to conform to a spending target that you weren't expecting.
Mhm.
So there's no real like you're not on a list for a certain period of time. It feels like a lot of change that could happen, year after year after year. A lot of, yeah.
Yeah, definitely. And I think that will be a consideration of whether or not they make any changes to that list. Already it's a challenge because they'll decide on they decided on these spending targets for say these hospitals in April of this year. But we know many of our members have multi-year contracts. They weren't necessarily up for any sort of renewals or anything. And so moving the barge or the boat in fairly short periods of time is challenging to begin with, and this could create the sort of whipsaw scenario that you raised there, Rebecca.
Sorry, another question. Although I understand just to kind of really highlight the high cost hospitals, but I was wondering because there are so many complex factors that contribute to a hospital's cost. And I was wondering if the agency has considered, for example, some hospitals may be serving communities that have just more severe health conditions because of their socioeconomic status. And other hospitals maybe because of their, I don't know, reputation or their specialties may be serving patients that have like very rare, diseases. And so that's super high cost. So just a pure number of high cost doesn't really tell a lot of the actual stories, I guess, about the hospitals.
We would love it if you came and testified at the at the board meetings. These are critical points that you definitely raise, and similar to ones we raised as well. There are aspects that their methodologies do an okay job of controlling for. So, for example, they don't just use volume, but they use a sort of acuity adjusted discharge measure to account for if your patients are more resource intensive to treat. So that was a good thing. But some of the things and then they do account for volumes, which is critical, of course. Some of the things we were disappointed that they didn't account for are we don't think they did a good job of always controlling for regional differences in costs. We know a nurse doesn't cost the same in Central Valley or up way north as it does in Santa Clara or yeah, San Francisco, and so forth. So that's why we do see this over concentration, I think, of hospitals in that list from coming from the Bay Area. For really high acuity patients, probably doesn't do a great job. For hospitals that serve disproportionate Medicaid patients, one of those hospitals there has extremely low, or maybe I'll do the reverse, extremely high Medicaid population. I think well over 50%. And that can be sometimes a more challenging population to serve, and it also comes with lower reimbursement, and those costs need to be elsewhere. And then like, for example, hospital, maybe even like Stanford, they're accepting transfers in for trauma care, complex procedures, where there's no contract for a significant portion of these patients. And, that typically goes along with higher reimbursement as well. And, so there are lots of these issues that I think their methodology didn't fully account for and results in that. I think somewhat, it's not the intuitive list of hospitals that you would necessarily think, if just thinking here at the state level. Thank you.
And Ben, have you heard about them looking at other sectors? So obviously hospitals are not the only providers. Um, you mentioned, physician groups and community clinics, and are they planning to do other sectors and other sector targets?
There are not immediate plans that I've seen, and so we will see. Their method. They don't need to create a sector. They don't need to create sectors to have oversight of most of these, or if not all of these types of healthcare entities. Why they would create the sector is to probably increase levels of scrutiny and oversight, and also set unique targets for some or all of the members of that sector, as they did with the hospitals. So we have not seen a large appetite. There's some sense they might look at specialty physician care as an area to focus on, but whether or not that results in the creation of a sector is yet to be seen.
I just had a quick question. This was a really helpful presentation. I'm curious what you think the role for an organization like EBLC can be in this. We advocate on legislation, but we also advocate on, other things that are not legislation. Like, what role can we play in helping with all of this?
Yeah, so I mean, OCA is an active forum for engagement and advice, and so we've certainly worked with similar organizations to provide comment on rules coming out from the office that could harm employers, harm businesses, harm patients, and so forth. So there certainly are opportunities to get involved with the office itself. Otherwise, we're trying to really educate lawmakers at the state level on challenges related to the office. And so working with local legislators and just educating them on what this office is and why it's important is really important. The legislature tends to have a short memory of laws that have passed even just a couple of years prior. So it's an uphill climb to sort of re-educate them on what this agency is doing. And to get, I think, some proper oversight and scrutiny. We made progress, but more could definitely be helpful. Rebecca, I'd open that up to you, or certainly others as well.
I think that's right, Meg. And if it's of interest to EBLC and the group, we can, Ben, it goes to their board. They meet, the OCA board meets like monthly, right? Practically. And they have items on their agenda every month. And, but we can certainly highlight those that we think are most critical times to weigh in. And I think it would be good to have voices other than, I guess I would call like the traditional healthcare providers,
I think
just to
we're
provide
unique.
that.
Yeah, we're a unique thing because we represent like the business community, but that includes healthcare providers of all kinds. So I think that, please send it our way. We'd like to engage and however way we can be most helpful. So
We will hold you to it, Meg. No.
yes, please do.
At least for conversation in this group, if, yeah. All right. Well, I recognize we're at time, but Ben, I want to thank you so much. And if you would want to share the presentation with me, that would be great. I think others would enjoy it. And then we did record this so that those who couldn't be here today can listen in, and I might listen in myself because every time I hear Ben talk, I learn something else about the office that I didn't catch before. It's a very important, it's playing a really important role, and it has a could have an outsized influence potentially on what our healthcare system looks like in the future. So something definitely to pay attention to. All
Thank
right,
you. Thanks
thanks,
for all
Ben.
the time.
Thanks, everyone.